welcome to Accreditation TV. Again, I've lost track of the episode numbers. I guess it doesn't really matter. Nobody really cares, but probably us and maybe the person that does a lot of video editing. So we appreciate you joining us once again. My name is Steve Sponbrook with MSL, and I want to introduce our subject matter experts, which we have Ramona Cheek, which most of everybody knows, who just brings a light to every room she walks into. We're so happy to have Ramona on the team. And Tim Adams, who also brings light to every room he walks into. And so today we're going to, hey, appreciate you guys being here. Today we're going to talk about team communications, particularly how they're kind of, if there's issues with team communications, they tend to show up during survey and some of the ways that that happens. But before we get to that, the first thing I want to do is remind everybody that if you have a question, please feel free to enter that into the Q&A section here of the webinar, and we'll be happy to try to answer those live. If we can't do them live, we'll answer them following this through email, or if you're one of our RN members, we'll be answering them through that portal as well. So, and speaking of RN members, if you're one of those and you want to get your CEUs, well, there went my phone, so it looks like Steve's getting a new iPhone. If you want to get the CEUs, you can get those through the platform as well. Just make sure you reach out to us for that. So with that, let's just go ahead and get started. One of the things that I think is kind of apparent now is with the accrediting organizations, particularly the Joint Commission, but all the AOs are really focusing on leadership and culture. And so team communications are one of the things that most survey teams use as a way of determining how effective leadership is in creating that culture. Is that a fair statement, you think?
I think so.
Yes.
Yeah. I think also what they're looking for is the communication from line of sight, those that are touching the patients, all the way up to the governing board. And I think, especially in Accreditation 360, what they really emphasize is the role of the governing body in understanding certain things like where they are with quality, where they are with policies and procedures, and that kind of thing. And they want to make sure that what they're hearing at the governing body level is the same thing that you're hearing at the frontline level. And I think it starts, and I think organizations have been working very hard on developing their mission, vision, and values, and communicating that, and that's really what also communicates the culture of the organization. But make sure that they hear everything the same, or the same echoes of the same themes from the governing body, the executive leadership team, to those staff that are taking care of patients. So they want to make sure that that flows throughout the organization. So I think that that's one of the key points that you'll see emphasized, that we've seen wax and wane. I mean, before there used to be a big emphasis on mission, vision, and values, and it waned off a little bit. But I think that we're starting to see with Accreditation 360 that come to light and to surface again.
Yeah,
I think it's.
go ahead, Tim.
Oh,
Sorry.
I think it's important too for those who are involved in the physical environment and support services and all those things. You're touching the patient too. Maybe not your hand, but you are touching the patient too. So all of the things that Ramona said apply equally as much in the physical environment, that it all should be pointing toward mission, vision, values, all pointing toward successful, compassionate outcomes for patients in the facility, and that all are working together as a team to achieve that.
Yeah, I totally agree.
Yeah, absolutely. I'm glad you touched on that. And I was having a conversation with someone just yesterday about how an interaction, and the first interaction I had with a health organization as a caregiver not too long ago was with a facilities mechanic in the parking lot. And it was really clear to me that that facilities mechanic understood the mission of that organization. And that set a tone for me, as well as gave me great confidence in the rest of the organization. I'm like, wow, maintenance mechanic, and I don't mean that in any way to be negative. But if this person understands and is empathetic and gets, why we're here, everybody else probably will as well. No, I can remember, way back when I did my MBA, and it started out, well, every good organization has a mission, vision, and values, and I thought, well, I remember thinking, why is that a big deal? But now, certainly much later in life, with MSL and us really, really wanting to live this mission of helping hospitals beyond compliance, because we just see how many opportunities there are out there to help improve the quality of care. I hope we do a really good job of communicating that, and I hope we also do a really good job of displaying that when we're out there. And I know that we do, because I get feedback all the time from clients that say that we do. But one of the reasons that you guys are kind of perfect for this subject is because, one, you've surveyed a lot, so you've seen it from that side, and we've already kind of talked a little bit about that, but we'll talk about that a little bit more. But you've also been on the other side of the equation, where you've been involved with multiple organizations as a team leader, where you've worked with multiple facilities. So I thought you guys would just be perfect for this particular topic. But so when we talk about team communications, and Ramona, I think you nailed it when you said starts with the board and goes all the way through the ranks of the organization. But what are some of the strategies? I mean, because I think most of the time the folks that tune into these episodes are the kind of quality folks and facilities folks that are kind of somewhere in between that board, senior leadership, executive leadership level, and the people down at the front lines working with the patients. How, if you're in that role, can you determine, what are some strategies where you can see, are we being effective with team communication or not?
I think one of the big modern ways that you're seeing about team communication has to do with the huddles that are taking place. And the huddles are taking place on multiple different levels. I mean, you have the executive team doing the huddle in the morning that has the overall lay of the land for everyone, and all disciplines are involved in that. I know that when I led the daily huddles, the team huddles, that usually last about 15 minutes. That's where you gave the overall picture of what was happening during the organization that day. And everyone lended what it is that they were looking at and communicated effectively. So I would know if there were certain things that environment of care was worried about, i.e. there was going to be a fire alarm episode or testing done that day, or that we needed to leave the water on because it was that time for water management, that every faucet had to be turned on. I mean, that was what gave the overall what's happening in that organization today. That's where we talked about the falls that were happening, and if we were having problems with bed alarms. So Central Supply would know, oh gosh, we have a lot of people that are on fall precautions. I don't have enough bed alarms that are ready. Oh, we might have to borrow some bed alarms from someplace else to have enough. So I do think that in the modern today that it is a daily huddle, and each leader then takes that huddle to portions of that to their team, and it goes down and down so that you have a huddle even on the shift level. So I think that's a way for the organization. I think that when surveyors come, they're looking for that team communication on several different levels, at that executive level, at the department level, at the unit level, and then how does that get to the patient? Because that's what we're all there. As you said, Steve, we're all there to figure out how this impacts the patient, and how do we communicate with that patient to let the patient know that what things are happening. And surveyors are looking at several things. From a clinical perspective, they're looking at how do you pass on that patient story. So they're looking at report and handoffs, and all those things are important. I always say when I'm in an organization that the only thing that provides continuity of care from that patient perspective is that medical record. And so how do we honor that patient story through our documentation? And documentation happens in several different places, not only in the patient chart, but sometimes in checklists that we do when we're doing rounds. I mean, so that's all honoring that story and what's happening through our documentation. So I think documentation and how we do that is an important part of how we communicate as a team.
And you had mentioned the huddles, which I think are a wonderful thing. Those involved, and I come from the physical environment side, so I'm representing that group. But those who represent and are involved in the physical environment at those huddles don't talk about things in terms of gallons, BTUs, tons of chilling, any of that. Talk about it in terms of how it affects patient care. And really all things that happen in the physical environment do impact care of the patients and the well-being of all the folks in the building, staff and visitors. And if we communicate more in terms of how it impacts people instead of how it impacts systems, that's a language that all can understand in a facility. Not all will understand tons of cooling and gallons per hour and all those other things, but we all can understand doing the right thing to care for everybody that's in our building.
Yeah, Tim, but they understand, you know what, because we don't have that tons of cooling, that it is going to be hot in the hospital and some areas are not going to be cooled. And they understand that. It's like, oh, we need to do something about that because, you know, we have an air handler down or it's not working to peak efficiency. And today's a warm day, so know about that. I mean, and that helps that communication because then we can set what the expectations are with patients and what's happening and why it's happening and assure them that we know that it's happening and we're working on it. So I think you're spot on by talking about it in terms of how it will affect the patient or the environment of which they are working.
So let me ask you, now I'm going to ask you to switch gears and put your surveyor hats on for a little bit. What are some examples that you've seen where it was obvious that communication was breaking down, where just during the process of having communications, you were able to see that even though they're saying the right things in leadership, or maybe they're saying the right things in other sessions, that at some point that communication's failing?
The one way is when they're not saying the same thing, the same answer to the same question. That if you don't have great working relationship, great communication on a daily basis, it shows up. No matter how hard you try to, I hate to say the word, but fake it, that we're all one big happy team during the survey, it shows up. When you're not on the same page, when you don't have at least a basic understanding of what happens in different areas of the hospital and how that impacts staff and how it impacts patients, it shows up immediately. And I see that happen.
Yeah. I think one of the big ways and primary ways is talking about the quality improvement plan and what's happening there. I mean, they will ask the leaders and the board, what is it that you track to know that you are hitting and doing what your mission, vision, and values say? And that's usually the quality plans. What things are you measuring? What data are you reporting and where you are with that data? And leadership and the board will paint a picture, and then they will go right down to that staff level in every department to say, what is it that you are doing to measure how you're affecting patient or each other? And they want to hear that same story. So they want to say, if you're tracking infections, if you're looking at falls, if workplace violence is something, if healthcare disparities is something that you say is important, they expect that the staff is going to be able to talk about that. And I have a great example. I was recently at an organization and had to it was a security guard was giving me a ride from one area to another. And during that ride, the security guard talked about what workplace violence, but he didn't even realize he was talking about it because he was just pointing out the homeless that we saw as we were traveling in that community, through that community, and said, one of the things that we are doing to address the homeless is we're providing food. We know that they are repeat in the ED, so we have an extra presence in the ED for that. And one of the things that we have made very clear is the violence, that it is not tolerated. And we encourage the nurses, we're right by there. This is what they have, panic buttons now. It goes directly to us. And if something happens, we are right there saying that we will arrest them. And we hope that people will press charges. I had heard that at the board level, but during that story, I said it clicked. It said everyone knows that this is something that they're working on, workplace violence. And they've identified the area that they're starting with, and he gave a story that supported that. So that showed that had communicated throughout. So I thought that was a great way of showing how what they were doing, and programs that they had chosen to do, indicators that they were following went throughout the organizations to the point of care.
I'm glad you clarified that you were going from one survey site to another, not
No.
to detainment or something like that.
You mentioned quality improvement, and I think what I see maybe most often in healthcare organizations and individual facilities is that the clinical side has understands what their quality improvement projects are and what they're working on and the connection. Where a lot of times in the physical environment side, if they are doing any type of quality improvement, it's because they think somebody's going to make them do it. Not as much from a standpoint of how does this truly impact our organization as, well, I got to have something to show the surveyor when they get here. I got to have something to show the state when they come. And so we end up, quality improvement is things like we will complete all our fire drills. Well, you don't have a choice. You got to complete them all anyway. So is that really improving quality, or is it just trying to improve to bare minimum? And I think there's opportunity in the physical realm to look at quality improvement as how does it impact patient care? How does it impact safety of visitors? How does it impact safety of our staff? And have that similar focus. And I bet in many organizations where they struggle in the physical environment to have the money to do what they need, and they truly don't have enough. I will say that in many, many cases, they do not have the funds to maintain the facility they have. But if the board knew what quality improvement is being done and how that impacts the overall organization, they might have a little different thought, or whoever's making those financial decisions, a little different thought about what, if we allocate these funds for something, what it's going to do. But physical environment kind of gets lost, and sometimes it's because we don't speak up and we don't really focus on quality improvement. We kind of focus on what do I have to do.
Yeah, quality assurance, which is a key point. I mean, you have to have that quality assurance before you can have improvement too, right?
Yeah.
Yeah, I mean, that's absolutely foundational. And from my perspective, you got to have QA before you have QI, and I think we focus so much on improvement that we don't even think about making sure that we're doing good quality assurance first. But you guys both talked a lot about the board and communication to the board, and the typical board meeting might be 2 hours once a month or once every other month, and there's usually other education opportunities that go along with that, and it's communication. But how do we get all the information that we need to the board in a way that they can actually absorb it and analyze it and be able to communicate that back down the chain of command? If you're sitting, because y'all both done this, right? You've been in that kind of quality. My job is to make us survey ready. You've been in that position. It's kind of a tough spot because you've got to manage up and you got to manage down. And so I suspect most people are thinking right now, it's like, well, how do I do that? So either one of you or both of you have any recommendations about how to manage up and down?
I think with the board, one of the most important things that the organization can do is to create that calendar of everything that they collect and do, and then put that on a calendar and have routine times when that's reported to the board, and publish that calendar so that everyone knows, everyone in the organization knows, this is when this section is going to go to the board, and so that everyone understands that. And I think that, and I think you're right, Steve. The board has a lot. I mean, they're responsible for everything that's occurring, right? So, and there's a lot that's occurring in that organization. So it's up to, I think, the leaders that are in charge of that to put that in a format that is manageable, that is routine, that is published, so that they know that it's coming and can talk about it. You can't talk about everything all the time, but you can prioritize what you talk about and know what are those things that you need to call out and make deeper dives on.
Okay. So, kind of getting back to the how it breaks down during survey. Any other thoughts on how we can help help our organizations avoid having these communication breakdowns, or even the appearance of one, because sometimes it might just be one little area that makes the rest of it look bad.
Well, a big area in the clinical realm with communication and teams communication is how effectively are we communicating that patient story among the team members and with the patient themselves. And so a big focus during a survey now is doing that care plan. Care planning, being able to document that care planning, showing that you've involved the patient and their family in that care planning. And that is something that usually I would say most every organization we go into, it's a finding that we have. The care plans don't either reflect the patient story that the nurse says is important to them, because a lot of times the technique I use is give me the patient story, and the nurse always knows the patient story. They can always tell me the patient story and what they're doing for that patient. And then I'll say, show me how you honored that patient story with your documentation. And so we go to the medical record, and guess what we find? Nowhere is that story that beautiful story that they told me of what they're doing, what their goals are, what they're looking for, what they've talked to the patient about. Nowhere is that in the medical record. And that is the piece that I would say most organizations, in talking about communication, have in being able to improve that, because the only thing that provides continuity of care is that medical record. That is what everyone is looking at, all members of the team. And so if something significant has happened with that patient, it needs to be contained in that medical record to reflect on that patient's story.
Yeah. I think one of the things I see frequently is a lack of, I don't want to pick on our people, Tim, but a lack of communication from the physical environment, engineering, life safety folks over to the clinical team in terms of what we're doing and why we're doing it. Ramona, you talked about water management. That was good. I was impressed. And, testing life safety stuff, I mean, that's good. But I think sometimes we do a poor job of explaining what we're doing, why we're doing it, and why it's important to the patient, frankly. So it seems like that creates some challenges sometimes, particularly when the clinical staff can't articulate why we're doing this stuff. Because going back to what we're talking about with communicating to the patient, the most likely person to have that communication interface with the patient is going to be the nurse at the bedside that says, hey, the reason their water's running in a shower for the next 10 minutes or whatever is there were, part of our, probably wouldn't say we're trying to prevent Legionella. I'd say something that's just part of our preventative maintenance or whatever. I'll let them figure that out. But, how do we improve that kind of communication from I think, the clinical team needs to be interested enough to listen to us tell those stories, and two, we need to figure out how to tell those stories in a way that are meaningful to them, not necessarily with all the details that are exciting to geeks like us.
I think on the clinical side, we expect a lot of that stuff happens in the background that we just take for granted. I don't, when I walk into a room, I don't think, oh my gosh, I wonder how many air exchanges are happening in this room, or whether the pressures are going the right way. I don't think about that on a conscious level every time. Physical environment does, and they make sure that it's happening right, and they come and test that to make, are my air exchanges right? Is the air flowing? Is my temperature right? I think that, so a lot of it is just explaining what you're doing, because we just take it for granted that it's happening.
Yeah.
I think it's important that the support services side, facility management and such, displays confidence on a daily basis, that not not cocky confidence that I'm an expert in this and we've got it. It's the confidence that just they are got their eye on the ball, focused on what needs to be done, are taking care of it because we care about supporting those who take care of the patients
Yeah.
and the environment. And it's it has to be intentional
Hmm.
to have that communication. One of the pitfalls of our modern technology, when many facilities, when you have a physical environment issue, you put in a request or a work order and it makes its way to the facility department or environmental services department, and somebody comes and takes care of it and closes it out. And if you go back in to see the status of your work order, and if you're a nurse, who has time for that? But if you go back in, well, you see, yes, it was completed, or it's taken care of, or no, it's not. But we've lost that personal communication. A lot of facilities used to have folks that did rounds from, say, the facility side, and periodically would pass through units or do, we used to call it zone maintenance, where you had a
Yeah.
facility person that was responsible for certain floors or certain units, and they were there every day and kind of checking in. And so you had this opportunity to have, sometimes very brief, but at least you knew somebody's watching the ball. With us moving toward electronic communication, team meetings, send an email, who knows where that goes. Sending an email is not communication. It's one way unless there's a response. But I think that makes it even tougher to know, is somebody got their eye on the ball? We used to
Yeah.
have a little more contact. And I'll relate, the first hospital I went to work for, I worked for a third party company doing clinical engineering, health technology management, facility management stuff first, and then went to a hospital. And my first day, I'm like, what do I do? you know, I'm used to going into facilities and having a very specific task or a scope of work. And this is what we're going to do. Now, kind of responsible for everything. I could easily spend days looking at inventories of equipment, preventive maintenance schedules, procedures, test equipment, calibration of test equipment. There's all these details, but I can only do that for so long. Then I get kind of weird. So I started right on day one taking a walk every day and just stopping in a unit. If I could find the manager, just sticking my head in, at first introducing myself. But then as we got to know each other, just kind of sticking my head in, how are things going today? And what's going on? Any new procedures you're starting to do in cath lab? And I didn't know all the details of the clinical world, but at least gained an understanding, and then encouraged my staff to do the same thing. When you're talking to folks, take just a second to get past the piece of equipment that you're discussing,
Yeah.
and kind of how are things going, or and it's amazing because all of a sudden now you're a team. When the surveyor comes in, it's obvious you're a team. It's obvious that you like working together, that you do work together. When there is silos, animosity, um, conflict, and then we all try to put on a happy face for the surveyor, you just see right through it. I mean, it's
Yeah.
so easy to see right through. These people really don't work together very closely, but they're all smiles and trying to. When our culture is that we work as a team to affect positive outcomes and compassion for people, when there's a survey, it all takes care of itself. It's just another day. We do what we do. We work together to do what we do.
Yeah, exactly. Well, let me throw I'm gonna throw a curveball at you, at both of you, and say, what about contracted services? Like we've got, traveling nurses, or maybe we've got a contracted facility management agreement or clinical engineering agreement. And so technically those folks are not part of the organization directly. What kind of challenges does that create? And you got any advice, words of wisdom on how to overcome those?
Well, yeah, because the processes that support those communicate are the same. So it doesn't matter. It doesn't matter if you're contracted. You're doing the same. You're using the same exact process as those people who are employed there. It's the same with volunteers. So if you have strong processes in place, it doesn't make a difference. In fact, I've been in many places where there have been construction workers that have been contracted. They're contracted. They've been there for years. People don't know that they're contracted. They feel like they are part of the institution, the organization. They know what's happening. They know names. We know them by name. So you have that connection, as Tim talked about. It's about establishing that connection, and you still need to have that. It's the same. There should be no gap. There is no different. I mean, a surveyor doesn't say, "Oh, wait a minute, you don't have to do this because you're a contract employee." They are under the same exact standards, expectations as everyone else.
Yeah.
And that begins with leadership. That what is going to be our standard, what is going to be our culture, no matter who you are. If you're here, a contractor doing repairs in the building, travel nurse, whoever it may be, having a standard and leadership demonstrating that, not just saying this is our culture, but demonstrating that. I visited for the first time years ago a facility, not too many years ago, that has to be the cleanest facility I've ever seen, cleanest hospital. You could not find a dust bunny anywhere. Even the mechanical rooms were clean and just clean, just obvious. And it wasn't a brand new building. It was part of it was built in the 50s. Most of it was built in the 50s. Older facility, just as clean as can be. I had been there 2 or 3 times before I found out that environmental services was a contracted service.
Wow.
But they took it serious, that we do our very best for every person who's in this facility. And it came from their leadership, who was not a hospital employee, but that person instilled that in the staff, and you could not tell the difference. Everybody had that same culture. Facility management, you didn't find a scratch on the wall. It got fixed immediately because there was somebody that took it very personal that this place is going to look good for everybody that comes in.
I hate to say it though, that seems like way more the exception than the rule when it comes to these situations. And, I think, at least from my perspective, that's always been one of the biggest challenges with contracted services is getting that mission, vision, value alignment all the way down through those. And maybe I'm just jaded and because I've had some bad experiences in my life, but, you know,
Well, I think it's more common now to have whole services contracted. I mean, it is common now to have your facilities contracted out, to have your human resources contracted out, to have your food service contracted out, to have your linen service contracted out. I mean, I think it's more that's kind of the operation of the modern healthcare organization is to have a set point of contracted out, but they are included and their expectations is exactly the same. So those contracted folks are there on the huddles. They're there doing the EOC rounds. They're there during the meetings that the organizations have. So you can't tell that they are a contracted service, and we're measuring them the same. So, I think it's become more seamless as we've gotten, as we use it more, and it's more common in most organizations to have something that's contracted.
and I think at least from where I see it being really successful and effective is when there's leadership sets those standards for those contracted elements. I mean, on the surface, it makes a lot of sense, right? A core competency of a healthcare organization is providing healthcare, not cooking food or working on a building or providing security or whatever you want to do. You can give a long list of those things, and there's a company that does just those things for their business should be better at providing those services than we could be as healthcare providers. As long as there's that strategic alignment, those expectations are set up front from leadership and communicated. And, so, you both have seen examples where it's worked really, really well. I've seen examples where it's worked really well, and I've seen examples where it was horribly wrong. And I think that all goes back to where we started, which is leadership setting the expectation and making sure that that communication goes all the way down to the lowest level. But that seems like a frequently an area that's if there's a weakness in that communication, a contracted element may be where it's the easiest to see, at least from my perspective. I don't know where you guys land on that statement, but
I think it really comes from leadership. If leadership's view is, I'm going to contract this service because it will in some way help us be better, help us be more effective in what we do, that's a great thing. If it's, I'm going to contract this service so I don't have to worry about it anymore, out of my hands, not mine. We cannot give away responsibility for the safety and for caring of our patients. You can't sign it away. You can't give it away. It's ours. And, we use other folks all the time, but when we treat them as part of the team and have expectations that they work and act and have quality as part of the team, then we're a team. We can be together and accomplish those things together, whether they get a paycheck from the hospital or get a paycheck from such and such a construction company or such and such a environmental services provider, whoever it may be.
Yeah, I actually think I'll have to go back and look at the calendar, but I think we do have a planned session on just contracted services and talking about that. But I think it was important to talk about it at least a little bit in this discussion because they are part of the team, and communication is critical. And that, to me, if I'm surveying and I hear that facilities, for example, because that's probably who I'm going to interface with, is a contracted service, all of a sudden my thoughts about, are they getting the message and are they living the mission, vision, values the way they should, I'm a little more interested, and I'm probably going to probe a little bit deeper than maybe I would otherwise. And I think it's probably true for everybody. Wow, this went by really fast. We blew through 30 minutes and we're almost into 40. You guys have any other thoughts about team communications? And
I just have a couple of other ways of communicating that surveyors might look at, and this is more on the granular level, but there's some national patient safety goals now, national performance goals that are still there, like the two patient identifiers, which everyone in the organization should know this is how we identify our patients. SBAR communication, a standard way of that we pass on information. And most people during report have a standardized way of doing report, whether it's bedside report or at the nurse's station, but that you have an organized way that you're sharing and communicating that patient story. Also, the read back in communication, so that if you're taking verbal orders, that you're reading back those orders, and then critical results. Those are the other place that we communicate, and how do you do the critical results. Also things that the surveyors are going to be looking at. So I just wanted to put that as a form of communication that the surveyors are going to be looking at on that granular level at that point of care with the patient.
great. I appreciate you adding that. Tim, you got anything else you want to add? Or
I think keep a focus on what we're there for, taking care of people, providing for people, and doing what's best for them. And maybe on the physical environment side, we've got so many rules that we have to follow and have to do this and do that, and we start looking at it as rules instead of looking at it as there's a reason the rule is there. There's a reason that standard is there. There's a reason we do this, because somewhere down the road, probably somebody died. Maybe lots of people died. I kind of always go back to who figured out, or how many people did you have to go through to figure out which mushrooms are poison? There's a reason that so many of the rules and regulations exist. And instead of focusing on, we have to comply, yes, we do have to. There's no choice. We have to do that. But focus on, how do we provide the best environment? Most of the time, I think many times, if we said, what's the right thing to do for the patient, we'll get the compliance pretty close.
Yeah.
Just
Well,
doing
becomes
what would, all other things aside, what's the best thing to do? So I think to help improve communication, the more that those who are not directly hands on with the patients, maybe have less contact with the patients, still are focused on patient care, patient outcomes, and supporting those who do that. It really improves that communication and just makes life a lot more fun, because at the end of the day, no matter what you do or who you are or what your position or tasks you do in the organization, you have made a very big contribution to somebody's life.
yeah, you're
And
doing something meaningful. That's why I think hopefully we're all in healthcare.
yeah,
Well,
yeah.
thank you both for your time, and thank you all who are tuning in for your time. We appreciate it very much. Again, if we didn't get to your questions, we'll definitely try to get them answered either through email or in the ARN platform. And if you need your CEUs, do that. And we look forward to seeing you here again in a couple of weeks for the next one. So, Ramona, Tim, thank you very much. As
Later.
always, you
Take
guys
care.
are knocked it out of the park. So we will talk to you again on the next one. Take care.
Thank you. Have a good day.